Good day, and I am Anna Nolte, and we're busy with our second session in the Mother Baby Friendly Initiative series of lectures. And in this session, we are going to do 4 lessons. We're going to do the anatomy and the physiology of breastfeeding. We're going to talk about the first feeding immediately after birth. We're going to talk a little bit related to the anatomy and the physiology about the frequency of feedings, but we will do much more about this in the second and the third session that we will do next time. And then we will talk a little bit about exclusive breastfeeding, just explaining what exactly is meant by exclusive breastfeeding. So as I've said, this lesson, we're going to talk about the anatomy and the physiology of breastfeeding. And for those of you who already know me, will know that the physiology, I'm an absolute physiology fanatic. I'm always saying you can't understand how anything about anything if you don't understand how it works. So if you understand how breastfeeding works, where it comes from, how the hormones function, you will understand all the other issues about how to improve milk supply, milk production, solve most of the problems related to breastfeeding. It's important that you should teach the mothers about the physiological aspects of breastfeeding so that also they understand it. So I really hope that you're going to enjoy this lesson. Okay, now when we talk about the exterior anatomy of the breast, I think all of you know the exterior anatomy of the breast because I think most of you are women. Now, we all know that we have the areola, the darker pigmented area around the nipple, and when we are doing the first feeding of the baby, you will see that this has some specific knowledge. We always thought it's just a darker pigmented area on the breast, and we never gave any attention to why it should be a little bit darker. But when you see specifically the video, the one video that I'm going to show you, you will understand that. Then there's the nipple, and then on the areola, we all know that there are some small glands that we call Montgomery glands. Now, as I've said, the areola is the circular pigmented area around the nipple. And what's very important about the nipple is that the nipple is composed of a lot of smooth muscle fibers. And the moment that the nipple is being stimulated by either touching or sucking, these muscles are contracting. To make the nipple, to make the nipple more erect, and this is obviously also very important when the baby starts sucking on the nipple. And on the nipple, there are also a lot of nerve endings, which we will come to, which obviously also play a role in this erection of the nipple, but also obviously in the whole breastfeeding process. On the nipple, there are many openings of the milk ducts, which we will come to just now. There are about 15 to 20 ducts that open here on the nipple, and the baby can get the milk out of the breast. And then we have talked about the Montgomery follicles or glands that's around on the areola area, and they secrete specifically during pregnancy and breastfeeding oily liquid, which tries to keep the breast, the area around the nipple being in a good condition. Now, if we look at the interior or the internal anatomy of the breast, we see that there are many alveoli. It almost works like in the lung, that there are many alveoli which are almost, I call them bubbles, and they are the glandular tissue where the milk is being produced and stored until the baby starts suckling, and then the milk moves forward. The milk moves forward in small ducts, and you will see that these small ducts eventually branch and they become bigger ducts, and these ducts eventually open on the nipple. And as I've said, there are about 15 to 20 ducts that open on the nipple. Now, what's very important is that we've always learned, and I'm sure many of you that's a little bit older have learned that there are some sinuses here in the milk ducts just behind the uh, um, areola. Now we will come to that a little bit later again, but there are actually no sinuses. What happened is in the past, before there were all kinds of wonderful technology like sonars and MRIs, etc., the only way that scientific people could understand how what the breast looked like and how it works, is that they had to do obviously dissections on cadavers. And what they did was to inject color fluid through these ducts, through these openings in the nipple, to see exactly how these ducts branch off and where they're going to, etc. And with the injection of these colored fluid, obviously it caused some widenings here in the ducts, and that's where the whole story about sinuses just behind the areola comes from. But what actually happens, and we will also come to that again, is that as the milk flows, as the milk starts flowing, specifically when the lay down reflex comes, these milk ducts, these bigger milk ducts here, just before it opens on the nipple, dilates. And that almost looks like sinuses, and that is where the sinus story comes from. Now, if we look at the other supporting tissue around these areola, we see that there are many fat and other tissues, which are more connective kind of tissues, and they determine the size of the breast. So how big or how small the breast is totally been determined by the amount of fat in the breast. It has absolutely nothing to do with the functionality of the breast. Now, if we look further in the internal anatomy of the breast, and we look at one specific alveoli of the one specific, almost I want to say, bubble of the alveoli, we see that the alveoli are being made up by small, what we call acinar cells, and these acinar cells are responsible for the production of milk. Each one of them get all the nutrients from the you see the acini cells here of the alveoli. Then it's been surrounded by small epithelial cells, which we will come to just now, and then it's surrounded by small maternal capillaries, blood capillaries, obviously. So when the right reflex and right impulses come, these cells, these acini cells, get the fluids, the proteins, the glucose, the leukocytes, whatever it needs from the maternal blood. It comes in these cells, and these cells are then responsible for the production of the milk. And then when the milk has been formed, they literally forms drops, and the drops fall into the space, into this alveoli or into this little sac, and then it's been moved forward. And the way it's been moved forward is by these myoepithelial cells that you see here that contracts under the influence of oxytocin, which we will come to just now again, but they contract and pushes the milk forward into the ducts. The ducts are also being surrounded by myoepithelial cells, and they also contract and makes the milk then literally move forward in an almost peristaltic way. And then, as I've said, these milk moves forward through all these smaller tubes, all the smaller ducts, until they eventually come to the bigger ducts, which open in the nipple and where the baby can get his milk from them. Now, if we look a little bit more in detail at the ducts, we see that the ducts, as I've said, they comes from the alveoli, and then they branch together and form a bigger ducts, etc. So what happens now is, under the influence of oxytocin, the myoepithelial cells are contracting, and this works. The oxytocin has been released not all at once. It comes in I almost want to say sessions. So it causes contraction of the myoepithelial cells for about 2 to 3 minutes. Then it relaxes again and then again, so that the milk literally moves in a peristaltic way through the ducts. So it's not like the baby starts sucking and you open the tap and the milk just flows. As I'm saying, it comes in a peristaltic way. And when we come next time to the attachment and latching, we will come back to this a little bit more. And the fuller the breasts, we have also said that when the baby starts sucking and the milk's being produced and the milk starts flowing, that we get ductal distension. As the milk goes now forward from the alveoli into the ducts to the nipple, we get that these ducts are getting distended. Just a few words on what happens to the breast during pregnancy. Now, during puberty, the breasts are being formed. All these alveoli and the structure of the breast, etc., has been formed during puberty. So by that, when the mother is becoming pregnant, we already have the tubular, the duct system, and the alveoli system. But during pregnancy, they further develop, and I will show you a diagram just now about the difference between a pre-pregnant and a pregnant breast. So under the influence of estrogen, all the ducts develop more, and under the influence of progesterone, all the lobules, the alveoli, etc., also develop much more. Now, we all know that during pregnancy, there's a lot of estrogen and progesterone that's being produced by the placenta, and they suppress the formation of prolactin and oxytocin. That's why the breasts are in a non-functional condition, if I can call it like that, during pregnancy. But there is a small amount of prolactin that's also been formed by the placenta, and they cause further development of the alveoli during pregnancy. It also is then responsible for a small amount of colostrum that starts to be produced in the breast from about 16 weeks pregnancy. So from about 16 weeks pregnancy, the mother can express small drops of colostrum from a breast. But the full production of colostrum can only start when the placenta has been born, the progesterone and the estrogen levels in the body is dropping, and then prolactin and oxytocin can start being produced, and that is the only time that full functioning of the breast starts. So the whole story about by expressing colostrum during pregnancy, the mother can increase her milk secretion or her milk production is definitely not true. Now, after birth, as I've said, the placenta has been born, progesterone and estrogen levels drop, and then prolactin and oxytocin come into full function, and the breasts can start producing. Here you can see the diagram of a non-pregnant breast here. The ducts are being there, they are fully formed, and there are small alveoli and kind of underdeveloped alveoli that has already been formed. And this usually happens, as I've said, during puberty. And then during pregnancy, under the influence of progesterone, estrogen, and a small amount of prolactin, we've said that specifically this functional part of the breast, the alveoli, are being developed to a very large extent. And this is mostly what's responsible for the increase in the size of the breasts during pregnancy. We start looking at the physiology of the breast. We have the so-called maternal reflexes and the neonatal reflexes. There are 3 maternal reflexes and there are 3 neonatal reflexes that's responsible for breastfeeding to work or to start working and to continue working. Now the maternal reflexes, first of all, we have talked about the nipple erection reflex. We've said that when the nipple is being stimulated, and in this case by the mouth of the baby, it will get harder and erected, and that makes the nipple to become longer, which makes it so much easier then for the neonate to suck it in, and we will come to that just now. Then we get the production of milk reflex with the so-called prolactin reflex, and we get the let down oxytocin reflex, which is responsible for the movement of the milk. And then when we look at the several neonatal reflexes, we get the rooting reflex, a sucking or a suckling reflex. It's actually a sucking and a suckling reflex. And then we get swallowing, and the baby swallows the milk. Now, all these 6 reflexes have to be there and to have to be well developed for breastfeeding to work. And we will go through them in the order that they are basically happening. Now, the first one, first reflex, is the rooting reflex. This is a neonatal reflex. This starts when the corner of the baby's mouth is being stroked or touched, and the baby will turn his head or open his mouth to follow this touch, this root, in the direction of the stroking. And this helps the baby to find the breast or the bottle to start feeding. And we will see how well it's developed in a term baby. We will see it on the video that I will show you on the first breastfeeding of the baby, how well this rooting reflex is already being developed and helps the baby to suck. And we all know that's basically what we use in most cases in breastfeeding, in getting the baby latched, which we will also talk next time in the next session a lot more. Now, this rooting reflex lasts about 4 months, and then it just gradually disappears. I think with my tongue in my cheek at that stage, the baby knows where the breast is, and he knows where to find the nipple, so he doesn't need this rooting reflex anymore. So the moment that the side of his mouth is being stroked by the nipple, he opens his mouth wide in response to the proximity of the nipple, and he thrusting his tongue forward, and this is very important in preparation to get the nipple into his mouth. And we will talk also a little bit more about that. While I'm saying we will talk a little bit more about that, I'm saying it often. You will hear a lot of things being repeated in this session and in these lectures, because it is so important. And you will also see how these things function together to make the whole thing work. So this reflect has 2 components. It has a tactile stimulation, where the area around the mouth of the baby is being stimulated, which causes him to turn his head. And then the second part of the component is that the mouth gapes in preparation to accept the nipple. In this, as we've said, he opens his mouth and he thrusts his tongue forward. Now, if we look further, then the next reflex that comes into function is the nipple reflex. Now, we've said that the nipple becomes erected the moment that it's been stimulated, and the baby's mouth is the most important stimulus for the nipple erection. And this nipple then becomes longer by the fact that it's been erected. It becomes longer so that it's easier for the baby to suck. And at the moment that the baby sucks on the nipple or starts sucking the nipple, it stimulates the nerve ends, or even just in the rooting reflex by touching the nipple, it already stimulates the nerve ends, which cause the contraction of the muscle vessels around the nipple, and that caused the erection. But this stimulation of the nerve ends also is responsible for this hypothalamus hypophysis reflex stimulation, where the oxytocin and prolactin is coming from, which we will talk about just now. Then the next reflex is the suck reflex. The baby has now rooted for the nipple. He found the nipple, he sucked the nipple into his mouth, and now he starts sucking or suckling, which we will come in much more detail just now. As we've said, rooting helps the baby to get ready to suck, and as the roof of his mouth is being touched by the nipple that he has sucked in, you will start to suck. And we can easily feel that also when you use your almost, I want to say, use your finger as a nipple. Use your finger to stimulate the rooting reflex at the side of the baby's mouth. And as soon as your finger touches the palate of the baby starts sucking your finger. So this is where the suck reflex is coming in. Now this reflex starts only being developed by the 32nd week of pregnancy, and it's only fully developed about 36 weeks. So this is very important for premature babies, and why premature babies can't really do breastfeeding, sucking on the breastfeeding. Obviously, there's a lot of individual differences. It might differ from baby to baby, but more or less, and we will come to this also again in much more detail when we are talking about the premature baby and breastfeeding. We're talking about the whole sucking and suckling reflex. Um, in breastfeeding, we call it suckling and not sucking, because you will see there's actually very little sucking involved in the whole aspect of breastfeeding. Now, what happens is, as I've said, is that the nipple is being the rooting reflex, and then the baby sucks this nipple, literally drawn this nipple into the baby's mouth. Now this nipple becomes about 3 times longer than what it normally is, and it extends back to here where you can see the hard palate and the soft palate reaches each other, so that when the milk is being pressed out of the alveoli, the nipple, that it can just go into the esophagus and the baby can suck. The baby's tongue this nipple is lying literally on the tongue of the baby, and here you can see the gums of the baby sitting here on the base, basically on the base of the nipple. If we look further at the process of suckling, as I've said, here at the base of the nipple is the baby's tongue, and here on the the upper gum and the lower gums are basically the two, I almost want to say, functional parts of the baby's mouth, which is responsible for getting the milk out of this breast. Now, the tongue, as we've said, cups around the teeth, forming a trough in which the nipple lies. And then the milk is being expressed. Remember, we've said as the milk is coming down now, there's a lot of distension in the ducts, and the milk is now being expressed by these gums of the baby from these widened ducts, and obviously it is being moved forward in the breast because of the let down reflex. So the baby is not sucking the milk out of the breast. He literally pushes the milk out of the breast because it's flowing forward now under the influence of the let down reflex. So his gums are pressing the milk out of this distended drugs. It comes through the opening of the nipple, and the baby, by pushing his tongue is forming kind of peristaltic movements here in order to get the milk out of the nipple, and the milk goes down the esophagus, and the baby can swallow the milk. And we will talk about the oxytocin reflex a lot, which, as I've said, make the milk to move forward. Now, what you see here on this side is a series of diagrams, and you see here on the bottom the name Woolrich, and it's 1986, so it's quite old. It's quite an old source that I'm referring here to. Now, Woolrich in 1986 have done a series of photos, and which he obviously then eventually put into diagrams. Have done a lot of sonars on exactly what happens in the baby's mouth when the baby is so-called suckling on the nipple, on the breast. So, and this is up to today still a very reliable source, and you will see in most of the breastfeeding textbooks, articles, they still refer to Woolrich. So we're still using Woolrich and to explain exactly what happens. So first of all, we get the pressure of the tongue here against the teeth, and the areola and the whole nipple is in the baby's mouth. And that, together with the ejection of the milk from the increased intraductal pressure, as well as the movement of the myoepithelial cells of the milk, the myoepithelial cells of the ducts, that moves the milk forward. So the baby presses with his gums here on these extended ducts, and that literally presses the milk out of the breast together with the lay down reflex. So there's absolutely no suctioning involved. What happens now is, as I've said, the upper gum and the lower gum presses here on the distended um, milk ducts. Then also, if you look at these arrows here, how the tongue works, the tongue literally causes peristaltic movements as it moves the milk that's in this nipple to the back of the mouth, so that it comes here to where the hard palate and the soft palate is. The soft palate moves, then moves to open, to close the pharynx, so that the milk can go into the esophagus and that the baby can swallow. The only negative pressure, so the only sucking aspect of breastfeeding, is that the baby sucks the nipple into his mouth and he holds the nipple there in place, and that causes a little bit of negative pressure. But further than that, there's no real sucking involved. So what I'm saying here in this sentence is very important. There is, when the baby suckles in this way, and we will get to when we get to latching next time, is that if the baby suckles in the right way, there is no rubbing of the skin of the breast or the nipple while it is in his mouth. So there should be no pain of the nipple if the nipple is in a healthy condition when the baby is sucking. And we will talk about that with latching again. Now we come to the milk production of milk reflex, the so-called prolactin reflex. Now what happens here is, the moment that the baby starts sucking on the breast, we've said that there are many nerve endings in the nipple. These nerve endings are being stimulated. This stimulus goes through to the brain, to the hypothalamus of the brain, and then from there to the anterior pituitary or hypophysis, where the prolactin is being formed. And this prolactin is responsible for the production of breast milk. So what happens now is that the prolactin goes to the alveoli, like I've said previously, the alveoli cells, and they draw water and the nutrients from the bloodstream to make milk. And now as the milk is being formed, and the milk is being formed, as you can hear from this, while the baby is sucking. So while the baby is sucking, remember I've shown you the alveoli. So the milk is being formed in the alveoli, and then it needs to move forward. When the baby drinks, the baby doesn't suck it out of the alveoli. It's supposed to move forward, and as it moves forward, obviously it empties the alveoli, and the milk of the alveoli, almost, if I can say it, call it like that, becomes empty, and that causes continued increase in the levels of prolactin. This emptying of the alveoli, if I can call it like that, causes the more prolactin to be secreted and more milk to be formed. So this part, this sentence, this paragraph here is extremely important. As the baby starts sucking, milk is being produced. As the baby removes the milk out of the breast, more prolactin is being secreted and more milk is being formed, at which the baby eventually can get out of the breast. So the more the baby sucks on the breast, the more milk will be produced. Now, what's very important with this sucking process as well, the moment that the baby sucks, and specifically early in lactation, it stimulates the development of so-called receptors to prolactin in the alveoli. So there are, in the alveoli, as it is, there are small receptors, which is very sensitive to prolactin. The prolactin stimulates these receptors, and that causes the production of milk. So the more the baby sucks, the more of these receptors are being formed in the alveoli in order to be able to react to the prolactin and to produce more milk. So this is basically the whole very important aspect of and principle of the production of milk. What's been saying here under NB is that prolactin is secreted at the highest levels with suckling during suckling, normal suckling during the day, but then specifically more so during the night. And there's not a known reason why there's more prolactin secretion during the night than during the day. But this makes it very important that babies, specifically in the beginning of breastfeeding, in the first few weeks of breastfeeding, should not have fewer breastfeeds during the night, because that is when most prolactin formation is being stimulated by sucking. So as much as the mother needs and wants her rest, it is important that the baby should feed it. When we look a little bit further at this whole prolactin reflex and what happens with the production of milk, as we've said, the milk is now being formed in the alveoli under the influence of the prolactin. And I've told you that the milk, the alveoli, the Alcini cells literally forms drops of milk into the alveoli, and they move forwards by the contraction of the myoepithelial cells. So it moves out of the alveoli and it travels then through the ducts to the nipple, where it's been expresses or compresses out of the breast by the baby, as we've seen earlier. Now, a very important, and you will hear this many more times in this whole series of breastfeeding, is the earlier and the more frequent the baby sucks, the more prolactin is being secreted or formed, and the more milk will obviously be produced because of that. Now we will talk about the importance of an early, why it is so important to breastfeed as early as possible, and this is one of the very important reasons. Remember, we've said early suckling, especially the first weeks of breastfeeding, more prolactin receptors are being formed, which obviously increase or will stimulate the production of milk eventually. Therefore, increased demand with more frequent and longer breastfeeding results in more milk production. And as I've said, that is one of the most important principles of milk production. A little bit more on production of milk, and a little bit more on specifically colostrum. Now, we all know that colostrum is the first milk that's been formed in the breast, produced in the breast for the first 3 to 5 days. And we all know, because we have learned that in the previous sessions, and we all know from experience, that it's a thick yellowish fluid, and that there's much more proteins and nutrients in colostrum than in normal breast milk, and these and also enzymes that helps the babies to develop the baby's digestive tract. So, and antibodies to protect the baby from infection. So these aspects of colostrum, these characteristics of colostrum are extremely important in making emphasizing the importance that the baby's first feeds should be colostrum feeds, because then you receive his digestive tract can develop so that he can digest all the milk that he's supposed to get. There are antibodies helps the baby to protect the baby from infection, and the proteins and the nutrients are in the correct relationships and quantities to meet all the needs of the baby. Now, this colostrum is being formed during the first 3 to 5 days of milk production, and then gradually it increases, the amount of milk also increases, as we've said now many times, according to the needs of the baby, which we will come to many more times again. And then from day 5 to about more or less 14 more days, we get transitional milk, which will eventually develop into more mature breast milk. Now we come to the last reflex, which is the lay down reflex, the movement of the milk. Now, again, when the baby sucks on the nipple, the nerve endings in the nipple is being stimulated, and this reflex or this impulse goes from the nipple to the hypothalamus again, and in this case to the posterior pituitary gland or the hypophysis, where oxytocin is being formed. And this oxytocin goes to all these myoepithelial cells that we have talked about that surrounding the alveoli and the ducts and cause the so-called milk ejection reflex or the so-called let down reflex, and that is therefore the movement of this is basically the movement of the milk from the alveoli to the ducts. Now, as we've said, this is very important. Previously, we've said it as well, that as the alveoli is being emptied, it further stimulates the production of prolactin, which stimulates further milk production. So the more frequent nipple stimulation and the more lay down, the more milk is being produced. But what is very important here is that it doesn't help if there's a lot of milk being produced and it doesn't move forward. It is not allowed to move forward because we need this forward movement in order for the baby to get the milk out of the breast. But we also need this forward movement for more milk to be produced. Now, as I've said previously, oxytocin is not the once-off release of oxytocin and we get a let-down reflex. It's been released in discrete pulses throughout the feet of the baby. And it, as I've said, it almost causes a peristaltic movement of milk. And we get what we say so-called bursts of active feeding or a flood of milk during breastfeeding. And we will come to this also in much more. Now, if we talk further about the let-down reflex or this oxytocin reflex, different people, different women experience it in different ways. Some women might feel a tingling, itching, or a warmth in their breasts when they have a let-down reflex and the milk flows in, or other experience it a little bit different. We will come to that just now. And we will come to it also when next time when we talk about latching and attachment. We also notice that initially when the baby starts suckling, it's more kind of short suckling movements, and then of the tongue and the mouth of the baby. And then as the milk comes in, the suckling slows down and the baby sucks slower, suckling slower, and begins to swallow rhythmically. We can see and sometimes even hear how the baby is swallowing. Now, in the early weeks, specifically for neonatal mothers, the let-down reflex might take several minutes before it comes. So it might be that the baby might start suckling a few minutes before we hear this slowing down and rhythmically swallowing story. And later on, it can come earlier, and later on, it even comes before the baby starts drinking, before the baby is on the breast, even only when the mother thinks of the baby or when the baby starts crying, she can already start experiencing the let-down reflex. Now, we will come to this just now, but the milk let-down happens best when the mother is relaxed and feeling comfortable. It's a kind of a positive cycle. When the let-down reflex happens, the mother becomes more relaxed because of the effect of oxytocin. But the mother has to be relaxed first before the let-down reflex can happen. And that's very. Now we also have what we call a so-called inhibitor of breast milk. Now there's not something as such, an inhibitor as such. It's basically more of a process. What happens is if a lot of milk is left in the breast, the cells stops from secreting any more milk. As we've said previously now for many times, when the alveoli cells are being emptied, more, it is a stimulus for more milk to be formed. So if the alveoli is for some or other reason not being emptied, when the baby dies, for example, or when the mother doesn't want to breastfeed or to stop breastfeeding for some or other reason, the breast stops from secreting more milk in order to protect the breast from the harmful effects of being too full. Now, this causes a feedback to decrease the prolactin secretion and the milk production. So it causes no more prolactin to be secreted, because, as we've said, the emptying of the alveoli is basically the impulse or the thing that triggers the prolactin secretion. If the breasts are not being emptied, it decreases then obviously the prolactin secretion. And the milk in the ducts and the milk in the alveoli will then be absorbed, and the alveoli becomes smaller and returns to its resting state. And the milk production ends. This is a normal kind of way. For example, if the mother decides to not breastfeed and bottle feed, for the breasts to stop producing milk. Now, we obviously helps it on with some medication as well to make it more comfortable for the mother and to make it sooner. But if we do nothing, if we just give no medication, this is the natural process that will happen. But unfortunately, this is also the process that happens if the baby does not empty the milk, the breast sufficiently. It's exactly the same process. So if we say, what we are saying here, that if breast milk is removed, if the baby is sucking well and he removes the milk out of the breast, the so-called inhibitor is being removed. But the moment that the baby is not emptying the breasts, this inhibitor, in inverted commas, stops the production of prolactin and therefore the production of milk. And this is also why sometimes one breast stops making milk if only the other breast is being given to the baby at regular intervals. So that's why it's so important that the breast should be alternated. Which breast is being first? This breastfeeding should be second. Now, just a few words on fore milk and hind milk. When the baby sucks from the suckling from the breast and is done now, it's finished, there's still a lot of milk in the breasts. There's still milk in the alveoli, and there's still milk in these distended ducts, and it's been stored there for in the breast until the next breastfeeding, while the baby is going to drink again. So when the baby starts drinking again, you will get initially you will get the milk that's in the ducts and in the alveoli. So remember, when the baby starts sucking, the impulse, the prolactin impulse, goes to the alveoli, and the alveoli starts producing milk then. So the fore milk, the milk that the baby sucks out, will almost be the stored milk that's been stored in the breast between breastfeedings. Now, what happens with this milk that's been stored here is that there's a little bit of the fat that's been in the milk that's been reabsorbed. So the fore milk has a low fat content, while the hind milk has a much higher fat content. It's still high in protein and carbohydrates, so the baby still gets protein and carbohydrates when he's drinking the fore milk. And it's a watery kind of milk, so it satisfies his thirst to a large extent. Now, I think it's a kind of almost a principle. If we are hungry and thirsty, we want to first quench our thirst before we start eating. And it's almost similar in the case of the baby. Now, when the baby starts sucking and the new milk is now being produced in the alveoli, these new milk that's being produced have big fat globules that starts being dislodged into the alveoli, into the center of the alveoli, and moved forward with the lay-down reflex. So the hind milk is the milk that the baby gets with lots of fat in, and the difference, as I've said, between the fore milk and the hind milk is the fat contents, which makes the calorie contents of hind milk much more than the fore milk, and that's also cause that the babies stay saturated or satiated for longer between feeds, and not become hungry so quickly. So that's very important. The baby needs the more calories to gain weight, and he needs the more fat to stay happy between his breastfeeds. Okay, and that brings us to the end of this anatomy and physiology session. So please complete your quiz so that you can go to lesson 2.